be more of a personal talk, more than like a theoretical or an academic talk. I'm going to talk about, what it's been like for me to be both a doctor and an anthropologist, and how my perspective has been influenced by being trained in both fields. I'm hoping I can help, especially some of the medical students who are here today, think about ways to bring an anthropological sensibility into your work. So I am going to talk about specific academic case examples from some of the research that I've done, but I'm more going to just talk very openly about kind of what it's been like to train in these two fields and how it influences my perspective now as a resident in psychiatry. So I did want to touch on a couple things that I've heard today in the last couple of panels about cultural competence. I share, the concerns that you brought up with the term cultural competence, and more than talking about, individual cultural groups and how to work with them, I think that as physicians, and really any healthcare provider, it's more that we need a broader framework in how we work with all our patients. And it's easier, even on a practical level, to train doctors and other healthcare providers in a framework or in a way of thinking, rather than trying to sort of teach people encyclopedic knowledge about multiple cultural groups. So I kind of wanted to start with that. Anthropology is the study of culture, and I'm a cultural anthropologist, but I identify more specifically as an applied anthropologist. And what that means is that I try to take the tools of anthropology and bring them into medicine. So I'm not one of the medical anthropologists who critiques biomedicine, although I share many of the critiques that came up today. I more want to talk about how do you work within the system to make change, like within your own clinical practice or within the institutions you work in. Because for me, as an undergraduate and as a medical student, I really wasn't satisfied with just critiquing biomedicine. I really wanted to get in there and work on the ground and work with patients and communities. So I'm going to try to talk about how we do that. And I think a lot of medical students feel that way. I don't think I'm alone. It can be frustrating to hear critiques from outside your discipline, of your discipline, when you're actually the one practicing it. So I want to talk about how we can actually apply some of these critiques in our lives and in our work with patients. So, so let me tell you a story, first of all, about going back, 7-8 years when I started my PhD work. So I worked with a Native American community in the Southwest. And the reason I'm going to tell you this story is I think it illustrates some of the concepts we can bring into medicine. So I was preparing to get my PhD proposal ready. And anybody who's done a PhD knows that's sort of a stressful time in training. And I had already worked with Native Americans as an epidemiology researcher for a year after finishing college before starting my MD PhD program. And during that year, I interviewed about 600 Native Americans clinically, so not anthropology interviews, but clinical interviews about depression. Just going through the DSM criteria for depression, going through the PHQ-9, which is a simple screening tool for depression. And I found that people often interrupted me in this interview, and they wanted to talk about all sorts of other things. They asked me questions like, what are you doing with all this data? Where are you going to take it? Why do researchers keep coming in here and flying in and taking data from us and then going away and writing these big papers? What are you actually giving us? And I was 20 and super idealistic, and I thought, these are really good questions. What are we doing with all this data? What is the point? And I think many people who go to medical school, I had this big vision of making a difference and helping people. And whenever you write a personal statement for medical school and you write, I want to help people, people always read that and say, you got to change that. That's way too much cliche. But it's really true. That's really why I went to medical school and wanted to help people. So I was struggling with how to help people when the people I was trying to help were so frustrated with me, right? So here's where the theory part comes in. So to try to understand this, I asked some Native American doctors and researchers to help me understand why these people were so frustrated and why they were reacting this way to what I thought was a very simple clinical interview. You know, have you been depressed over the last 2 weeks? How do you feel guilty or hopeless? What are you doing with all this data, doctor? So I asked them, and they introduced me to a few terms that I put on your handout. So the first one was historical trauma. And you know, those of you who have had courses in psychiatry or mental health may know that Native Americans have the highest rate of suicide in this country, higher than any ethnic group. And historical trauma is a common explanation for why. So when we talk about trauma, what that means in psychiatry is an experience in which an individual feels their life is threatened, their life, their physical body, their well-being in some way is threatened. So that's at the individual level. Historical trauma is at the group level. So what I mean by historical trauma is when the well-being of an entire group of people has been threatened. You know, so you could use this term to apply to, Jews because of the Holocaust. You can think about African Americans and the experience of slavery. And for Native Americans, we think about policies that the federal government had in place, as recently as the 1970s, promoting assimilation and promoting essentially the extinction of culture, right? So Native American children were forcibly taken from their homes and put in boarding schools where they were not allowed to speak languages they spoke at home. If they did, they were very severely punished, sometimes sexually abused. Land has been taken. I mean, you all know your American history, so you know the traumas Native Americans have faced, right? But how do individual people respond to that? And what does that mean for the experience of healthcare? And how does it affect the way a doctor interacts with the community and with individual patients? Those are sort of the things I was experiencing. So the particular community where I was, like all Native American communities, had had its land taken, had had treaties broken, trust broken with the federal government, all kinds of inequalities in terms of healthcare allocation. So until recently, when the Obama administration changed their funding allocation, Native Americans individually were allocated less in healthcare dollars than federal prisoners. So we've had serious disparities, right, in this country. And that's what people were responding to. They didn't see me necessarily as me. They saw me as representing an outside force, representing biomedicine, representing all of this trauma. So, going back to being 20 and all idealistic and save the world, I didn't know how to respond. I mean, I felt really sort of crushed under the weight of this history. Like, what am I going to do? I can't turn back the wheels of time. I can't make people all of a sudden trust me or trust biomedicine or any of that. So I was looking for answers, and I learned about community-based participatory research. So at the time, I was a researcher, more so than a clinician. Now I'm more training as a clinician and starting to bring these things together. But the concept in community-based participatory research is that the community sets the research agenda, and the community decides even how research will be done. So I bought into that model, started graduate school, and decided to actually do my Ph.D. work on what Native Americans think about research, about biomedical research specifically. So I decided all those questions they were asking, what are you going to do with this data? Why are you zooming in here and leaving? I decided those questions were worth exploring as a cultural phenomenon. So what does research do to people that have been historically traumatized already? So I decided I was going to look in particular at genetics research because it was a hot topic at the time in Native American communities. And I found a tribe that was engaging in genetics research, which was uncommon because many Native American tribes have fears of research, particularly of genetics research, for a variety of cultural reasons that I can get into later if we have time. But I found a community that was, I thought, diving into research, and I wanted to explore this because, again, I'm applied in my anthropology lens, and I really wanted to see how do you do research in a productive way that's not traumatizing with a community like this. So I wrote this proposal and asked, permission of the tribe's health department, and my proposal was soundly rejected. And they told me that they didn't trust me because I was an outsider, and they were afraid that I would learn things from tribal members that were valuable, and that I I would share that with the genetics research group they were trying to negotiate with. So the tribe was trying to negotiate all kinds of intellectual property terms, like shared patents on genes. They wanted shared profits. They wanted to veto any publication that didn't reflect them in a good light. So they were engaged in community-based participatory research in this intense way, and they were negotiating. And they were worried that if I got all this insider info, I might hurt them. So that's, again, historical trauma coming right back in my face. So, I decided I was going to try anyway. And I went back to the tribe and I said, okay, I'm not going to ask you anymore for this whole, 2-year commitment of me living in your community and doing my Ph.D. work. Long-term anthropology fieldwork is done that way. You live in a community, you try to get an insider's view of things. We call that participant observation. So I came back and I said, give me 2 months. Let me come out for a pilot summer. Let me work with you, with the community, to design a research project that fits your needs. And if you don't like me, I literally said this to the health director, if you don't like me, you can kick me out after 2 months and you'll never hear from me again. But if you like me, then maybe you might agree to that whole 2-year thing later. But give me a shot. So they accepted. And after the 2 months, we had come to an agreement on a project, and the terms included, that my publications could be vetoed by the tribe, that they could review everything I wrote, and that I had to give something back to them. They wanted something concrete, and what they wanted was a research regulation board, akin to an IRB, an institutional review board, which is a board at a university that regulates human subjects research. They wanted the same, but they wanted it to be run by the tribe and run by the tribal government, and they wanted me to set it up. So those were the terms, and my thesis advisor said, who the heck agrees to having somebody veto their publications? Come on, it's publish or perish, you can't do that. And I said, I think I'm going to have to do it, otherwise this project, won't fly. And so I took a risk, and he said yes. So fast forward, 9 months later, I go back to the tribe to start my 2 years of fieldwork. And the tribe tells me I'm not allowed to do any interviews till I finish that IRB. So I spent the first 9 months working for the tribe, not doing any interviews, developing my questions, trying to build trust. And this is going to come to a point I want to discuss later about what it means to medicalize mental illness, and I'll explain the connection. So once I started doing my interviews, once the tribe was happy that I had sort of given them something first, they had gotten something tangible out of me first, then I was allowed to start my interviews. And I was told, don't introduce yourself as an anthropologist. It's not going to go well. Don't do that. Anthropologists have hurt Native Americans. The Smithsonian and other museums still have skeletons of Native people. Just don't do that. It's like, all right, well, I'm going to introduce myself then. So I introduced myself as a medical student. And I got a lot of credibility because of it. So, before we sort of say that medicalizing mental illness is totally a bad thing, let's talk about the prestige medicine carries and the respect it carries in this country and what it means to carry the title of doctor and how people respond to you. People will open up to you when you say you're a doctor in ways they won't when you say you're an anthropologist. So I introduced myself as a medical student, and the first people I was able to interview were people I met because I took care of their children in the pediatrics clinic. So I volunteered my time as a medical student. I worked in pediatrics clinics with a hugely pregnant Native American pediatrician who couldn't lift kids onto the table, and that was my job. I hoisted Native American children onto exam tables. So that was my entree into the community. And as people got to know me, they had a lot of questions about me. And as medical students, I'm sure all of you have been trained in sort of how to present yourself as a professional, right? We have a lot of professionalism lectures and training. And when you first start going into the hospital to do those initial patient interviews, and when you do your standardized patient interviews, you're supposed to carry yourself like a doctor. You wear your white coat and walk around. And you introduce yourself in a certain way, you carry yourself in a certain way, you're careful in how you touch or don't touch patients, right? All of that in anthropology is what we call presentation of self. It's a concept from Erving Goffman. who was at Penn, an anthropologist at Penn. And essentially what it means is the way that you create a persona for yourself out in the world, right? So I found that that presentation of self in this historically traumatized community, this community that was so deeply hurt by past research abuses, I found that presenting myself as a researcher was a problem, but presenting myself as a doctor in training was acceptable and was something totally different. So sort of coming to today, and what does this mean now? I find that I struggle with this presentation of self piece every day. And I think that if we really want to engage with all our patients in a manner that's healing, in a manner that's culturally respectful, it starts with looking at how we present ourselves. And so, initially people would ask me questions like, what tribe are you from? Because I have dark skin. That really mattered to people. It wasn't enough for me to say I'm a medical student. Okay, that's fine. What tribe are you from? And I didn't really have a good answer because I didn't want to appropriate Native American identity. I didn't want to masquerade in any way. So I would say, I don't have a tribe. I'm not Native American. But then I decided maybe this would be a good conversation starter. So then when people would say, what tribe are you? I tried out one day to answer by actually saying what background I'm from. So I said, oh, I'm from the Punjabi tribe. And people were like, what in the world is a Punjabi tribe? and they were like, I've never heard of that tribe. Where are they from? And I would explain. I would say, Punjab is the land of 5 rivers, and my people are from there, and that's my tribe. I'm Punjabi. It's that simple. And so then people started saying, oh, so you're another kind of Indian. All right. So the clinical distance that we create, that we are trained in, right? As doctors, we're trained not to talk about where we come from, not to talk about our families, not to talk about sort of who we are outside the hospital. When you walk into the hospital and you put on that white coat, you become sort of the neutral, calm, therapeutic presence that is a doctor. But that just did not fly with this community that had been historically traumatized. What mattered was that I connected with them on a personal level, that I was human, right? So it's the humanizing aspect of the clinical encounter that I'm trying to get at here. So, eventually people, asked me about my family. They were very surprised at 24 I didn't have children, because on the reservation this is an anomaly. People started having children at 17 or 18, so I was old, to be childless. But people got to know me, and I learned to open up in ways that I was not trained to do in medical school at all. It was uncomfortable for me. So I sort of had to toggle between, okay, I'm a medical student, and I'm an anthropologist too, but there's this identity of med student, identity of researcher, and then identity of just being plain old me, right? And I think that when all of you who are medical students start stepping into the clinic and engage more with patients, understanding this concept of presentation of self can actually be quite healing, because there are times that we strategically do marshal other parts of who we are in the way we treat patients. And it's okay. It's okay to do targeted, careful self-disclosure. And it doesn't mean telling your whole story and making the patient listen to you. But sometimes it can really change rapport. And rapport is everything in psychiatry, Other fields of medicine too, but in psychiatry, if a patient likes you and has faith in you, they're going to take their medication. And medication noncompliance is a leading reason for patients not doing well in our field, right? So I'm just trying to illustrate all this with examples that are sort of concrete and specific, because I think that a lot of the terminology we use can be very theoretical, but actually, how do you do this? This is how you do it. You sort of look at yourself first, and that's cultural humility. So more than trying to become culturally competent in different groups, you look at yourself first. You try to understand what culture you come from, not just ethnically, but understand that medicine is a culture, that within the culture of biomedicine we have certain values like clinical neutrality, the authority of the white coat, how we sort of distance ourselves from our patients. If you understand all that as a value system, and that's all that it is a value system, you can learn to select which value system or which identity you're going to bring forward yourself in a given moment, with a given patient, and in a given setting. So that's what I mean by presentation of self, and I do feel it is a powerful source of healing historical and individual trauma in terms of working with our own patients. So the last thing I want to say, I won't kind of go on too much longer, is that more concretely, Within anthropology, we have a different style of interviewing than we do in medicine. In medicine, a lot of our interview questions are very closed-ended. I know in psychiatry clerkships, they always teach you to start with open-ended questions. When you're seeing a psych patient in the ER and you have 10 minutes, that just goes out the window. You know, are you depressed or not? Yes or no? Come on, let's go, right? So it gets very closed-ended. But ethnographic interviewing, which is sort of what I did in the field as an anthropologist, is very, very open-ended, and what you seek is the patient, or in this case, you know, the interviewee's own view of the world, right? And culture is, in my opinion, it's just a way of looking at the world. That's how I define culture. So there are ways, though, that we can bring that same concept into medical interviewing. And that's the little list of questions on your handout up at the top, explanatory models. This is a concept many of you probably know, developed by the famous psychiatrist and anthropologist, Dr. Kleinman. And he took these ideas in anthropology and operationalized them in a concrete way to develop sort of this concept. So an explanatory model, put simply, is a way that the patient understands their own illness. And if you as a doctor understand their understanding, you can negotiate what we call a shared explanatory model, where you have your view, which is steeped in biomedicine, based on biology, and you can understand how a patient sees their illness, and then bring those together by negotiating a shared view. And that's, again, critical for things like treatment compliance. So these are a few questions that you can try asking in your clinical interviews if you sense there's a difference. It doesn't have to be used every time, but if there's a patient who seems to have a different understanding than you do, or you're frustrated, or feel like you're hitting a roadblock in communicating, you can try this as a way to build rapport. So you can ask questions like, what do you call this problem? And this is a way of getting around language barriers as well, and cultural barriers. So instead of trying to be culturally competent in another ethnic group's, way of looking at things, you can say, what do you call this problem? What do you believe is the cause of the problem? What course do you expect it to take? How serious is it? What do you think this problem does inside your body? How does it affect your body and your mind? I love this question. What do you fear most about this condition? Because that answer may vary. And what do you most fear about the treatment? Rather than struggling when someone says, no, I refuse to take pills, I hate pills. All right, what do you most fear about them? Like, ask that. It's easier than sort of trying to challenge head on these perceptions. So I guess I'll just conclude with that. It's like I tried to offer you some, personal reflections and specific tools that you can, I hope, use in clinical work. And I'm happy to talk more with anybody about all of this. So thanks for having me.